Wonderful. So thank you for coming to session 8 of our Foundations in Critical Care webinar series. We're really happy to have all of you. This session is on ACLS, behind hospital walls, successes and pitfalls in inpatient cardiac arrest response. I'm here today with my partner in crime, Andrea Komisky, who is an emergency medicine doctor and ICU doctor at Stanford University. Um, and then also with some of our amazing panelists from across the globe. Another partner is Dr. Rachel Kimani, who works at Bagathi County Hospital in Kenya. Dr. Rachel is an anesthesiologist, also works in critical care and other subspecialties of perioperative care, and is a renowned global health expert. Unfortunately, Dr. Eugene was not able to make it today. Dr. Chitra Venkat Subramanian is also an intensivist at Stanford, but also a neurologist. So we're super happy to have Dr. Chitra here today to offer her perspective from a neurologic stance. Dr. Lawrence So, also Major Lawrence So, is an emergency medicine doctor also working in critical care at 37 Military Hospital Association in Accra, Ghana. Very excited to have Dr. Lawrence with us today. And also Dr. Hans, but also Colonel Hans Garcia is an anesthesiologist and intensivist coming to us from Colombia. Also very excited to have you with us this time as well, Hans. So with that, we will get started with some of our introductory slides. We want to remind everyone that we want this to be a safe place of learning. So we want to encourage everyone to be respectful to others. If you disagree with someone, please do so with respect. This is a learning environment that uses the Q&A function at the bottom of the screen. So if you have questions about the materials, please feel free to put them in the question and answer box. Similarly, we want to build community. We have people from all over the globe. We love to have you all here. Feel free to introduce yourself in the chat. Tell us your name, where you work, and in which country you work. This session is being recorded. That is your consent to be recorded. The session or your engagement is consent to be recorded. The session will be posted on our Learning Resource Center, and we are also live stream on YouTube currently. We recognize not everyone is a native English speaker. We will all try to speak slowly and clearly. Additionally, there is closed captioning available on the Zoom platform that may help you with English language. This is the link, the QR code link to the Learning Resource Center. All slides, materials, and after the session, the recording will be posted here on the Learning Resource Center. Feel free to access that and share it with others who would like to learn from this series. Here's the QR code for our YouTube channel. This session, as well as all of the previous sessions, are hosted on this YouTube channel for you to look at either now live stream or on demand later. And as most of you know, we do offer some CPD or CME credits. We will post this slide again at the end of this session, but if you registered, you will automatically receive an email and a certificate of attendance. If you follow the instructions on the email, you should be able to receive Stanford CME credits. So with that, I'm going to switch slides to our presentation here. Apologies for going back and forth. Okay, and with that, we're going to start off with ACLS behind hospital walls, and I'm going to hand it over to Dr. Komisky. Thank you so much.
Thank you, Dr. Crawford, and welcome everybody. We're very excited to have you all here for webinar number 8, which is hard to believe. And so, as Dr. Crawford has already alluded, today we will be discussing ACLS behind hospital walls, the successes and pitfalls in inpatient cardiac arrest response. So, as a brief overview, ACLS or Advanced Cardiac Life Support are guidelines that have evolved over several decades. The guidelines are based on scientific evidence of variable strength and expert consensus. The American Heart Association and European Resuscitation Council have developed the most recent ACLS guidelines in 2020 and 2021, respectively. The guidelines are continually reviewed and updates are published periodically in order to give us the most current and up-to-date information that we can use in our practice. Today, we're going to be going over the learning objectives stated here. Of note, after this webinar, this is not considered an ACLS certification activity, so we will not be covering the specifics of ACLS, just breaking it down into different components. But today we will be analyzing inpatient cardiac arrest scenarios. We're also going to try to recognize how team dynamics, protocols, and the environment can outpack the incomes, good or bad, in those scenarios. We will apply best practice to improve in-hospital code response and discussions amongst ourselves on how we can do that, and then try to identify some system level improvements based on the case outcomes as well. And here, this slide refers to the chain of survival, which is a sequence of linked events that, when they are performed in rapid succession, they're thought to significantly improve the outcome of survival after sudden cardiac arrest. The chain of survival is slightly different between the in-hospital and out-of-hospital location. And so, for example, a in-hospital arrest needs early recognition and then activation of the emergency response within the hospital setting. And similarly, the out-of-hospital arrests need early activation of an emergency response, but this may involve ongoing ACLS during transfer to a hospital or higher level of care. Regardless of the location, however, cardiac arrest survival depends highly upon good quality CPR, defibrillation when it is indicated, and reversal of the cause, as well as the appropriate post-resuscitation care.
Thank you, Dr. Komisky. Now we'll hear from Dr. Hans Garcia.
Thank you, Dr. Crawford. Okay, let's begin. This is our patient, is Mr. Ortiz. He's a 64-year-old male. He had significant coronary artery disease, hypertension, hyperlipidemia, and he was recently admitted for an acute myocardial infarction. So we are the code blue, the blue code, the mega code, and we are called to help this patient. This is what you get on the monitor. So we are going to give you 20 to 30 seconds. We want to hear in the chat what's your diagnosis.
This is, thank you, Dr. Garcia. This is what everybody loves, is these ECG images and strips to determine what is happening to the patient. And I love how you brought this case and jumped right into this abnormal rhythm. So everyone put your answers in the chat box here. What is this rhythm? Give you 5 more seconds. See lots of answers coming in.
This looks great. This is really good.
Okay, what is the answer, Dr. Garcia?
The answer is our ventricular fibrillation. Yeah, you were really right.
Okay, wonderful.
So we got our patient. Our patient is pulseless and with this rhythm. So what is the next steps? What can we do for this patient? At least give us three first options to manage to treat this patient.
Okay, so you see ventricular fibrillation in your patient. What are 3 things you do immediately? I'll give you a few more seconds to answer. Okay, 2 more seconds. Perfect.
Okay, that's great. Everybody says CPR and defibrillation, and some of them are also saying about adrenaline or epinephrine, and there are the 3 options that we have to start our case. So right now, let's review. This is the ACLS algorithm, and it's the same for all the pulse patients. So we have ventricular fibrillation, ventricular tachycardia, asystole, or pulseless electricity activity, so the PEA. For all of them, we really emphasize that we need to improve the quality of the CPR. And please, it doesn't matter if there are shockable rhythms or non-shockable rhythms. We need to continue during the first phase of the blue code, the high quality CPR. You have to note in this algorithm that the shockable rhythms include just ventricular fibrillation and ventricular tachycardia. So we only are going to shock these 2 kinds of rhythms, not the other 2. And we have to continue all the CPR while the defibrillator arrives. So Mr. Ortiz, he is in ventricular fibrillation. We are calling for the blue code if they are available, so we are part of this team. And during this time, you can see that the provider has to start great high quality CPR. The other part of the team, they have to follow some tasks. Oxygen, place the IV or intraosseous access, or somebody can help with the trolley for the defibrillator, place the defibrillator using the paddles or the pads. At the same time, one of the team has to be in charge of medications. And for medications, remember that usually we are going to start and use all the time epinephrine or adrenaline. This sequence or process should be placed in all the hospitals, and we need to continue in training with all of our teams in all the scenarios, emergency, OR, or at the ICU.
Perfect. Thank you, Dr. Garcia. So without delay, the most important thing is to start high quality CPR, isn't it? So maybe we can hand over to Dr. Lawrence to tell us more.
Okay, thank you, Anne. So the next step is that for every ACLS, the foundation is good BLS. And for every BLS, the foundation is what? High quality CPR. So I'll give 20 seconds for us to talk about what qualifies as high quality CPR. So on the chat, you can put what qualifies as high quality CPR. What do you understand by that?
Okay, let's let our learners answer in the chat. What are some characteristics of high quality CPR?
Yes. Very good answers coming in. Push hard, push fast, yes. Rate, presence of ETs, end-tidal CO2, yes, very good. Compression rate of 30 to 22 breaths, very good. Minimizing interruptions to at least, yeah. So those are very, very, very good answers. And I'm happy seeing all those answers. So let's go through them one after the other and see what qualifies as high quality CPR. So with high quality CPR, there are 3 basic characteristics. That's you have to push hard, push fast, and push well. So push hard, you have to push, the compression must be at a depth of at least 2 inches. Or those using centimeters, 5 centimeters. And you have to push fast at a rate of 100 to 120. Not more than 120, not less than 100, to make it a high quality CPR. And then whilst you are doing this, you have to always allow for complete recoil of the chest so that you have venous return back to the heart for you to compress it out. So allow complete recoil of the chest, which is very important. And another important thing is that you have to minimize interruptions. So your interruptions, pausing when it is not time for you to pause for and checking pause, interrupting to intubate when it is not necessary, interrupting to do interventions that are not necessary. So interruptions must be minimized. And another important thing is that your ventilation, when you are doing a positive pressure ventilation, you have to avoid excessive positive pressure ventilation so that you avoid regurgitation of stomach content that the patient may aspirate. So avoid excessive positive pressure ventilation. So just enough to cause chest rise. So bag enough to cause chest rise. Another important thing that you need to look at is the compressor. If you start doing chest compression, you can easily get fatigue. So as much as possible, change your compressors when the compressor is tired or during your pulse and rhythm check. That's every 2 minutes. And then you should do this chest compression for adults at a rate of 30 compressions to 2 rescue breaths. And whilst you are doing this, the aim is that if you are able to attach an end-tidal CO2 monitor to it, you should be looking at your end-tidal CO2 should be greater than 10 to 20. And that will give you an indication that your chest compressions are adequate. If it is less than 10, then which means your chest compressions are not adequate. These are the markers. Thank you.
Thank you, Dr. Lawrence. Yeah, I think these are very, very important points, especially allowing the chest to recoil. So I think it's good for us to think about what we're actually doing within the chest with high quality CPR, and that recoil of the chest, allowing the chest to expand in between compressions, is really facilitating venous return back to the heart. And continuing that, the chest compressions is what builds up that pressure that allows not only venous return, but then the cardiac output when you squeeze the heart itself. We realize that end-tidal CO2 is not always available. It's not a widely available monitor, but when it is, having that end-tidal CO2 greater than 10 is telling you that you have adequate cardiac output and venous return. Thank you so much for going through that with us. Okay, I think Dr. Chitra is next.
Hey, everybody. So as we saw in the chat, everybody loved to shock. So we have 2 shockable rhythms, which is ventricular fibrillation and ventricular tachycardia. So the types of shocks that we can deliver depends on the defibrillator that you have available. If it is a biphasic defibrillator, the initial current that we use is 120 to 200 joules. If you don't know what the maximal current that is deliverable, or if you don't know how many joules are there, just give the maximum one if it is unknown. The subsequent doses, if the patient still needs to be defibrillated, should be higher than the ones that you initially gave. Now, the advantage of using a biphasic defibrillator, biphasic is the current goes from one direction to the other and then bounces back from the other direction to this one. So it helps us get away with less energy compared to a monophasic defibrillator, which is, as you can see there, 360 joules. And getting away with less current means there's less tissue damage, there's less chance of tissue injury and burns. And biphasic also helps us overcome any tissue impedance much better than a monophasic. But if monophasic is all that we have available, then we do it at 360 joules. And remember, the defibrillation is only for these 2 shockable rhythms, VFib and VTach.
Thank you so much, Dr. Chitra. I think one other thing we could mention that's not written in the slides, and I would love to hear from all of the panelists, is the placement of the pads or the defibrillator pads themselves. Sometimes we have defibrillators that have the hard defibrillation pads that come with the machine that are not stickers. They're actually the hard plastic things. And other times we have stickers that we can apply to the patient to deliver the shock. I think when we have the stickers, we sometimes will put one on the left chest and one on the right chest, but we also will sometimes put one on the front of the left side of the chest and one on the back. What is your experience, Dr. Garcia, in your setting? Which types of defibrillator pads are available, and where do you place them?
We have both of them, but there are many hospitals that only have the hard paddles, not the adhesive. Usually, the recommendation is when our patient has some devices like pacemaker or internal defibrillator, we have to verify where it's located. Usually, they are on the right side, on the left side, but sometimes there are some indications and they have to move to the right for infections or for other clinical indications. So we need to verify, we can destroy this item. And the same when the patient is really sweat, we need to clean before using the paddles. If not, the shock is not going to work perfectly. So usually we use it as you recommended.
Would you place, if you had a patient with a device in the upper left chest, such as a pacemaker, would you place the paddle below that on the left side?
The lower is going to be trying to be lower from the apex. So no problem with that. The problem usually is with the upper paddle. So in the left side, there's no problem. Usually more than 10 centimeters, there is no problem. The problem is when it's in the same side. The preference is we have the adhesive and use it, as you said, one on the back, one on the front.
Adhesive. Okay. Gracias. And Dr. Kimani, what is your experience with the paddles versus the stickers, the pads?
Hello everyone. In my experience, what I usually see is that when you use the pads, the adherence is better compared to the sticker, because at times the sticker, you don't know the quality of the supply is different, so it easily gets out. But should you get a good pad, the delivery of the energy is still the same, and in most scenarios you'll have you'll have the shock being delivered and it's adequate.
Okay, thank you very much. That wasn't on the slide, but I thought it was a practical point that maybe we should discuss. So we started this part of the discussion with what are the three things. Dr. Garcia asked us, what are the three things we would do for ventricular fibrillation? And the first was high quality CPR. And then Dr. Chitra helped us with defibrillation. But many of you also mentioned to give adrenaline. In our setting, we call it epinephrine, but it's the same as adrenaline. And that's to be given 1 milligram every 3 to 5 minutes. Dr. Garcia also mentioned that it requires a team to deliver ACLS. Someone's giving high quality CPR, someone is doing the defibrillation, and then there's another person that should be responsible for administering medications and another person who's recording the time, how often we give these medications. So we can give epinephrine or adrenaline 1 milligram every 3 to 5 minutes. Amiodarone is another medication that helps with dysrhythmias, and so we would give a 300 milligram bolus of amiodarone to help with that dysrhythmia. If needed, we can give an additional 150 milligram bolus as a second dose. Lidocaine is also mentioned as an antiarrhythmic, and we can give 1 to 1.5 milligrams per kilogram. A second dose can be given as 0.5 to 0.75 milligrams per kilogram as well. So those are some of the medications we can use to help with this patient's ventricular fibrillation. Dr. Garcia, can you tell us a little bit what happened with Mr. Ortiz?
Okay, I can see the slides. So I don't know if you're sharing the slides or not, but
cannot see them.
I can't see them. Maybe it's me.
you able to see? I didn't change anything.
Maybe it's me.
I can see them.
Yeah, okay.
Sorry.
Okay.
Lucy.
So finally, with Mr. Ortiz, the team did an excellent job. So it was really good. The CPR was done in the first 30 seconds. They start the CPR, high quality CPR. The emergency team response arrived really 2 minutes is really a good time. In my hospital, it's gonna take 10 to 15 minutes when the elevators are not working. So it's really complicated. Mr. Ortiz was defibrillated successfully, and epinephrine was given 1 milligram IV. So we can see Mr. Ortiz has returned to spontaneous circulation within 6 minutes. So congratulations to the team. Mr. Ortiz, he hasn't had any neurologic damage. The recovery is really successful with the implementation of the chain of survival.
Excellent job for the team who saved Mr. Ortiz, and he did not have to follow up with Dr. Chitra because he had full neurologic recovery. So that's perfect. Thank you, Dr. Garcia.
Thank you, Anna. So
what do you think the keys to success were for this good outcome?
So our keys was related first, the early detection. We need to be close to the patient, talking with the patient, the physical examination, and the monitoring. And with the monitoring, we need to detect these rhythms, they are shockables or not shockables. And then we need to activate the team, the blue code, the mega code. And for the teams, I think that is really important to practice, to get training, because when we need to work together as a team, we need really a strong communication skills and the leadership from one of us. Usually, sometimes we don't have all the team, 5 person. Usually, we can be only 1 or 2 people taking care of these patients. So we need many tasks to be done just for 2 or to 5. And finally, the correct ACLS steps. So we need to take in consideration to have a checklist for the CPR. Sometimes we can forget some of the recommendations, but we can read during the cardiac arrest, and it's going to help for our patients.
That's perfect. I'm glad that you mentioned strong communication and leadership. We'll talk a little bit more about this, but if you don't have the good role assignments and leadership, oftentimes you have a lot of people coming to one place. It can become quite a lot of chaos instead of an organized team working together. So I think that's an important thing to mention. Dr. Kimani, can you tell us a little bit more about the teams that assimilate for the ACLS?
So when you're doing the ACLS, more often than not, you need more than 2 hands. So you can't do it on your own. So you have to have a whole team of 6 people, and each of them has their role. So in the 6 team people, in the 6-person team that you have the resuscitation team, and also now you have the team that deals with the leadership roles. So for the resuscitation team, you're aiming at maintaining the patient's airway. So you have somebody who's standing at the airway. Sorry, just one minute. Sorry about that.
No problem. We understand.
So yeah, so you have the resuscitation team. You have the person who's managing the airway. So they want to make sure that the airway is patent, that you're providing adequate ventilation, that you're not also giving too much positive pressure ventilation. And then you also have now the other person who's doing the chest compressions. You want to make sure that they're doing the right chest compressions, the way we've discussed them. You want to also ensure that they're doing the cycles well. So every 5 cycles for 2 minutes, alternating now together with the defibrillator. So in this, when the person is doing these chest compressions, there's now the other person who's responsible for the defib whereby they're ready, the defib is ready, it's working, and they know how to use it, and they're ready to shock, alternating with the person who's doing the chest compressions. So amongst now the resuscitation team, there is now the main leadership team, whereby these ones are, there's a team leader who is giving instructions. He's assessing what members are doing or assigns the team members, their roles, and also makes decisions and gives feedback. This person is very crucial because in a resuscitation, if you don't have a team leader, it can be very disorganized. You can have instructions coming from different people. So you need a team leader who'll be able to assign roles and also analyze and see what is being done and offers the next mode of treatment or management. Then you have the person who's administering the drugs, one who knows how to probably dilute the drugs, one who is an ALS, who has ALS provider certificate and is understanding what drugs should be given and at what dose through the instructions from the team leader. Then you also have the time recorder. So they're able to tell you at what point are we changing the cycles, at what point do we give the medication, do we give another cycle of epinephrine, do we give a third cycle of epinephrine, what should be done next. And this person records the time and also records the time of the whole resuscitation process to see for how long can we continue resuscitating, or once we get ROSC, what next, can we stop? So it's a 6-person team that requires a lot of coordination.
Yeah, thank you so much. This is very, very important to understand this team, but also to make sure that you have people in the hospital setting that are on call for when a code is called or when a patient needs ACLS. I would almost argue that it might be a 7-person team because the person doing compressions needs a buddy, so they switch out every 2 minutes. Because if you're doing CPR correctly, as Dr. Lawrence mentioned, you will fatigue quite quickly because it does require a bit of strength. Many of us will practice these scenarios in simulation, and so when the real thing happens, we're ready to assume our roles. I think it's important to also recognize that the team leader usually does not step out of their role. They stay in that role so they can keep the whole scenario, the big picture, in perspective. Thank you, Dr. Kamani. That was very, very helpful on how to organize on these teams.
I've seen somebody asking, how do you assign a team leader, or who is the team leader? The team leader could be the primary nurse. It could be the in charge in the ward. It could be the medical doctor. It has to be somebody who's ready to take the authoritative role and understands how ACLS is done and how it's conducted. It can also be.
Yeah, I think that's a great question. They need to understand ACLS very, very well so that they can continue to direct the team to take correct actions. Another question may be who should manage the airway? I think we would have the most experienced airway person manage the airway. This is sometimes a respiratory therapist for a brief period of time until we secure the airway, and that might be an emergency medicine physician, an anesthesiologist, or someone in the intensive care unit. Similarly, who administers the medications? Sometimes this is a nurse, sometimes it's a doctor. If you're in a more highly resourced setting that has pharmacists readily available, sometimes we have pharmacists who will actually administer those pull up the medications and then hand them to the nurse or the physician who will actually administer them to the patient. So great question.
So we'll have questions here. You can put them on the chat box. The first one is, how long would it take to defibrillate your patient in your clinical setting, wherever you work? Do you have a code trolley on each and every ward? That's in the PACU, ED, OR, or ICU. Do you have a code team with a process to identify the leader and other roles?
I think this is a very interesting set of questions. It tells us a lot about the different settings in which we work. All of us work in different settings with different resources available. Would almost like to develop this into a survey so we could understand the challenges that people face.
Let me see what they've written.
How long would it take for you to defibrillate? What are the answers for that one?
Someone says at least 4 minutes. There are code trolleys in every ward. That's John Moravy. And also in the imaging suite, someone else says 10 minutes. Can keep your answers coming.
Regarding the code trolley, I think it makes me think of the recent publication of the African Critical Illness Outcomes Study that recognized that most critically ill patients are outside of intensive care units. There was another point prevalence study performed in high resource settings as well as low resource settings. So in places like Malawi, but also places like Sweden. And it identified that 90%, almost all critically ill patients are found outside of intensive care units. So I think those studies help us to recognize that these patients that may be critically ill at high risk of decompensation are oftentimes not in the intensive care unit. They are on the general wards, they're in the recovery room after surgery, they're in the emergency room, and sometimes we even have code blues within the operating theater itself. So it's important to have those trolleys and teams ready.
Okay. So just to help understand, you need to defibrillate as soon as you notice the rhythm is a shockable rhythm. So within 2 to 3 minutes. And to add on to it, every ward or every unit in the facility needs to have its own independent trolley, which is well stocked. At least there's a handover system in the hospital whereby somebody, when they're coming in shift, they know that the trolley is stocked or whatever is missing needs to be replaced as soon as possible, and have somebody responsible to ensure that that trolley is available whenever it's needed when you're doing a code. When it comes to now assigning the teams for the code team, this should be done probably at the beginning of the day. So this is in our setup or the facilities that I work in. We do it at the beginning of the day. So whoever is coming for that shift, we have an already assigned code team that has that knows their defined roles. So it helps to reduce the confusion that would happen, especially when you're doing a resuscitation. During a resuscitation, your adrenaline levels are so high you can hardly think. So when you at least have those roles defined early enough, you have the success rate is higher.
Yeah, it's excellent points. I'm an anesthesiologist and an ICU doctor, but I also have lots of other colleagues that have the same skills. So when I walk to a code blue, I know I'm going to assume either one or two roles. I'm either going to be the airway expert because I'm the only anesthesiologist that walks into the room, or I'm going to be the team leader. But if I walk into the room and I see that I have, for example, Dr. Komisky there, then I would probably allow her to be the team leader, and maybe I would just focus on the airway, but we would work with each other to determine who's taking which role. I want to make perfectly clear, and maybe I'll have some fun with Dr. Garcia and maybe give him a quiz, so our learners can be 100% clear on which rhythms are shockable, which rhythms are not shockable. So maybe I'll pick on Dr. Garcia as well as Dr. Komisky. So I'll give them a quiz. Dr. Komisky, would you shock asystole?
No.
Dr. Garcia, would you shock ventricular tachycardia?
Absolutely.
Dr. Komisky, would you shock ventricular fibrillation?
Always.
Dr. Garcia, would you shock pulseless electrical activity, or PEA?
Please don't do that. Never.
Okay, so our two shockable rhythms are ventricular tachycardia and ventricular fibrillation, correct?
Correct.
Okay, muchas gracias. Okay, Dr. Chitra, how are we doing?
Mr. Ortiz did fantastic because we all saved him. But the question is, why did he have a cardiac arrest? And why did he need it to be resuscitated? Why did he need ACLS? So he was admitted in the hospital, if you remember, with an acute myocardial infarction. And unlike in-hospital arrests, patients in the hospital setting are more likely to be monitored. They have undergone history, they have had physical exams, they've had laboratory work, they have imaging investigations. So let's think through why Mr. Ortiz ended up having a cardiac arrest after being admitted in the hospital. So please put in the chat some possible causes of his collapse and his arrest. So we'll give another 15, 20 seconds for this.
Thank you.
Wonderful. Great answers coming through.
Perfect.
Yes, everybody nailed it. It's the 5 H's and the 5 T's. So unlike in a pre-hospital setting where patients come in a cardiac arrest, when they are in a hospital, many of the reversible causes for cardiac arrest can be and should be detected early for patients in the hospital so that they don't end up in cardiac arrest. This means that with good history, good physical exams, investigations, and monitoring, many of the cardiac arrests that happen in the hospital are preventable events in the inpatient setting. So it's important, as you can see on the slide, there are these 5 H's and 5 T's that we identify them and fix the problems before they worsen and potentially lead to cardiac arrest. Understanding and addressing these underlying causes is essential for effective ACLS and can significantly impact the likelihood of achieving ROSC, which is return of spontaneous circulation. So the 5 H's and 5 T's are the 10 reversible causes of cardiac arrest that we continue to systematically evaluate while we are providing good quality, high quality CPR and defibrillation and other resuscitation efforts. So when we look at the 5 H's, for example, we have hypovolemia, we have hypoxia or hypoxemia, we have excessive hydrogen ions, which we call as acidosis. We like the H there, so we put it there. Then hypokalemia or hyperkalemia, so low potassium or high potassium, and hypothermia. Each of these has very distinct signs and requires very directed specific treatments. For example, if somebody is hypovolemic, then we give them fluid resuscitation. And if the reason for the hypovolemia is blood loss, we restore that by giving blood transfusions. If it is hypoxia, we make sure that their airway and their ventilation and they have adequate oxygen supply. If they have acidosis, then we correct the acidosis. If they have hypokalemia or hyperkalemia, then we adequately reverse those as well. And this is very important so that as we are continuing the CPR, we fix the underlying problem as well. Similarly, when we look at the 5 T's, we have cardiac tamponade, we have toxins, we have tension pneumothorax, and thrombosis either in the pulmonary, which is PE, or coronary, which is what Mr. Ortiz unfortunately first came in with. So again, there are various physical signs that we can look at. For example, if you have a tension pneumothorax, you have unequal heart lung sounds on either side, you might have tracheal deviation. If they have PEs, you're having chest pain, they have tachycardia, the QRS complex is narrow. If they have, toxins, hopefully we have found that from their history and medications that they might have been taking. If it's cardiac tamponade, muffled heart sounds, narrow QRS, and elevated JVD, and so on. And again, hand in hand with the CPR efforts that we are providing, there has to be very directed treatments towards these 5 T's. So for example, for cardiac tamponade, you need pericardiocentesis and thoracotomy, tension pneumothorax, needle decompression, and then insertion of a chest tube. So these are the 5 H's and the 5 T's that we would think of when we are assessing Mr. Ortiz to figure out, why did he actually have a cardiac arrest in a monitored setting.
Wonderful. That was excellent, Dr. Chitra. Thank you so much. I like the way you framed it because sometimes when we're taught ACLS, we think this patient is coding. Why did they code? It's the 5 H's, 5 T's. But I think it's better to think about in the hospital setting where patients should be monitored closely. If we see 5 H's or 5 T's, we need to address them so the patient doesn't have cardiac arrest. So thank you so much for going through those. Dr. Lawrence, can you start our next patient discussion?
Okay, thank you very much, Anne. So after having successfully saved the first patient, let's look at the second patient. So second patient is Mrs. Gupta. She is a 78-year-old female who is on her post-op day 3 from an open reduction and internal fixation after a fall at home, resulting in a hip fracture. She had an unremarkable intra-op and then post-op, and then she has been working with physical therapy to improve her strength. Whilst they were checking, she was on monitoring, and at a 4-hour vital checks, we were called to the bedside of the patient. So when you got to the bedside, Mrs. Gupta is unresponsive. You feel for her pulse. That's a carotid pulse, and the carotid pulse is undetectable. On the monitor is what is shown on the screen. This is what you see on the monitor. So the question is, what are the next steps you will take in addressing this patient? What will you do next? What are your immediate steps you do next? So I'll give 20 seconds for us to answer on the chat box.
I want to know if Dr. Comiskey is going to shock this patient.
Okay, so very good answers coming in. Some are saying don't shock, start CPR.
The answer
Yes, start CPR.
is high quality CPR when you can't feel a
Start
pulse.
CPR. Yes. So just something to add to that. Anytime a quality ACLS starts with a BLS. So anytime you have a patient who is unresponsive and you cannot feel a pulse, patient is not breathing spontaneously, you cannot feel a pulse. The next important thing is you start CPR, high quality CPR. The word is high quality CPR. And then you continue with the rest of the algorithm based on whether it's shockable or non-shockable. For this patient, what you saw on the monitor, he has no pulse, and then we saw some electrical activities. So that's a pulseless electrical activity, and which is not a shockable reading. So you go through the non-shockable reading algorithm. So the pathway for non-shockable reading. Thank you.
Wonderful. Thank you.
So as Dr. Lawrence has already alluded, Ms. Gupta has pulseless electrical activity, or PEA, on the monitor. So CPR is assigned to a junior nursing student who has not completed his or her BLS or ACLS training, and then the team leader wants to defibrillate. But you argue that this is not a shockable rhythm, so you keep saying that. It takes about 5 minutes to obtain a peripherally inserted intravenous catheter, or IV, and epinephrine is then given as CPR continues. So as you can see here, there are some strays away from the typical ACLS guidelines within the time frame, as well as the usage of different people for utilizing CPR. So in thinking about this, there are several delays in care that we can identify. And so one of which is that there is a delay in recognition greater than 2 minutes for noticing that the patient is in PEA and needs to have CPR initiated. The CPR in this scenario is noted to be late and shallow, so slower as well, so not necessarily giving the appropriate forward force that's needed to get blood elsewhere to perfuse, or allowing for the appropriate time for preload to return to the heart. There's also no IV ready within a noted amount of time, and so giving medications in a prompt manner was delayed. And then there was also noted to be some rhythm confusion. So whether or not there is PEA versus asystole, maybe even VFib, and unfortunately, no ROSC was achieved with this patient in a very short period of time.
All right. So Mrs. Gupta was unfortunately not as lucky as Mr. Ortiz. Um, Return of spontaneous circulation was finally achieved after 25 minutes. And before she was found in distress in the hospital, there was an unknown amount of time that Mrs. Gupta did not have any flow, or she had a low flow, meaning it's suboptimal to sustain the vital brain functions. And this happened prior to the code blue call. And as Dr. Kaminsky went over, there was inadequate compressions and a lot of other factors that led to the delay in care in providing CPR and return of spontaneous circulation. So Mrs. Gupta was determined finally to suffer anoxic brain injury, and she had a minimal neurological exam, maybe either comatose or posturing, but did not return back to her alertness and to her consciousness. And ongoing discussions with the family and with the care team regarding long-term care plans were started. I know later on in the webinar, we will come back to post-resuscitation care, particularly as directed towards the brain functions, and I'll step in at that time.
Thank you so much, Dr. Chitra. Dr. Rachel, are you able to tell us more about what happens when we don't adhere to the ACLS protocols? I'm not sure if...
Rachel, you are muted. Dr. Rachel, you're right.
Thanks, sorry.
Sorry. So that was a study that was done to check the effect of adherence to ACLS protocols in hospital cardiac arrest events. So this study aimed at looking at if we follow the protocols, what is the percentage of having survival, or what is the percentage of having return of spontaneous circulation? And if we don't follow the protocol, what happens? What is that percentage? So it in this study, what they concluded, or what it concluded, is that with adherence and correct actions for each cardiac arrest event, we had good outcomes. There was increase in survival rate. There was an increase in return of spontaneous circulation. And for the ones that did not follow the protocols as indicated in the ACLS algorithms, the majority of the, okay, not majority, a good number of them did not survive or did not have a return on spontaneous circulation. So as a conclusion, they said adherence to these protocols is very paramount in in increasing your survival rate or in having a return of spontaneous circulation. So this same protocol also tried to understand the number of wrong actions that were done, and once the wrong actions were done, what was the effect? What was the return of spontaneous circulation? So an increase in having wrong actions led to patients not surviving or patients not having ROSC, even at the time and also timing. The timing at which we administer the drugs, the timing at which we administer the defibrillation, the shock rhythms also had an effect on the times and also the return of spontaneous circulation. So it just emphasized the fact that we need to adhere to these protocols. And as we're adhering to these protocols, we need to be keen on what action is being done, how long is that action being taken, is it taking for it to be executed, and what is being omitted throughout the protocols. So some of the things that were contributing to this, we had issues on training gaps. So you have maybe staff who come in, they don't have a background on BLS or ACLS training, or maybe their certificates have expired and they have not renewed the certificates. So there was an issue on training gaps. There was also an issue on confidence level. Some also felt like maybe they were not too confident in offering the adequate CPR, or were not confident in using the defibrillator. And there's also the access to appropriate equipment, whereby maybe facilities could also be missing out on defibrillators, or also could be missing out on some drugs in the trolley, or having equipment that is missing out. So these barriers were attributed to the deviation from ACLS protocols.
Excellent. Thank you, Dr. Rachel. I think these are all very, very important things to realize. There's a lot that happens during ACLS, a lot of different steps, a lot of different people, medications, procedures that all have to come together in a very organized fashion, starting with that high quality CPR that Dr. Lawrence keeps telling us about. So I think we didn't do so well for Mrs. Gupta. So I want to take us to another patient now. This is case number 3, Mr. Johnson, who is a 60-year-old male on vasopressors for septic shock in the intensive care unit. A code blue is called within 2 minutes of his vital sign changes. Epinephrine 1 milligram is given twice, the last dose just prior to defibrillation. There was a long time taken for his pulse check when CPR was suspended for intubation. So asking the audience, the learners in the chat, which is your next step for VTAC in a monitored arrest? This patient's in the intensive care unit and was witnessed to have this VTAC or cardiac arrest. Would you resume compressions, defibrillate again, replace the endotracheal tube with an LMA, or give a higher dose of epinephrine? Okay, so the answer is to resume compressions. You do not want to have long interruptions in your compressions. Mr. Johnson has just received a shock, but his VTAC rhythm persists. High quality CPR should be given for 2 minutes before the next rhythm or pulse check or defibrillation attempt. So do not take a long time in between checking for pulses and defibrillating. Immediately go back to high quality CPR. So we're going to go back to our ACLS algorithm once again.
Yeah, so now we're going to review ventricular tachycardia again. And please note that once you recognize that the patient has one of these rhythms and is in fact pulseless, you should proceed immediately with high quality CPR, as we have already denoted. We emphasize the term excellent CPR because anything short of this standard does not achieve adequate cerebral and coronary perfusion, thereby compromising the patient's chances of neurologically intact survival. So if you do achieve ROSC, what their neurologic function will be afterwards. Note that the shockable rhythms include VFib and VTAC, as we've already discussed, and that PEA and asystole are not shockable rhythms. Please also continue high-quality CPR while waiting for the defibrillator device to arrive at bedside, because defibrillation attempts in order to just continue with that perfusion of all the end organs. And after you shock, you should proceed immediately to CPR unless the rhythm converts and ROSC is obtained at that time.
Perfect. Thank you, Dr. Andrea. This is a good example. Mr. Johnson's case is an example of straying from the ACLS algorithm or protocol that Dr. Rachel was telling us about. Dr. Hans, can you tell us a bit about what's happening in Mr. Johnson's case? What's going right and what's going wrong?
So there are many decision points that can influence the final result of the patient. So we need to review anytime when we finish a CPR code or a blue code. For example, in this case, multiple epinephrine doses were given before defibrillation, and we need the epinephrine. Definitely, we need it. We talked at the beginning, the three keys are CPR, defibrillation, and epinephrine, but it's just one each 3 or 5 minutes. Not anymore. That's the recommendation for the AHA. Second is the delayed recognition of reversible causes. It is important to know the rhythms. As Dr. Komensky tells us, shockable rhythms and non-shockable rhythms, we need to verify. Is really easy, even if we don't make the difference between ventricular fibrillation or ventricular tachycardia. Both of them are shockables. So we need to go, because the success in this kind of rhythms is going to be better, and we have the option for defibrillate. In the other cases, we need to go to the H, we need to go to the T's to get this cause and try to reverse. And finally, with the pulse check and intubation. Usually it's going to take many time. And for example, in intubation, if you are not really well trained in that ability, sometimes laryngeal mask could be an easy way. It's more easy if you have the device. But we need to try to don't interrupt compressions. Anytime that we are losing doing compressions, is going to be bad for the heart. It's going to be bad for the brain of the patients.
Yeah, I think one thing to recognize here is going to defibrillate the patient or going to do an intubation to secure the airway to not take too long, that those compressions are really the most important part. So especially when people are trying to intubate, if they don't get it quickly, go ahead and resume the CPR.
And so once you have return of spontaneous circulation, or ROSC as we've talked about, the next best thing to do is post-resuscitation care, because it becomes crucial to stabilize the patient and then prevent further injury from occurring. The priorities are to optimize ventilation and oxygenation by maintaining the oxygen saturation between 92 and 98%, while using an advanced airway and, if available, waveform capnography, and then trying to avoid hyperventilation at the same time. Simultaneously, you do want to treat any hypotension, and that is essential by maintaining the systolic blood pressure over 90 or a MAP greater than 65, using fluids and then reaching for vasopressors as quickly as needed. It is imperative to address the reversible causes that have been identified throughout the resuscitation process with the H's and T's, and trying to reverse those as well and treat them accordingly. And so a 12-lead EKG should be obtained promptly to assess for potentially a STEMI or a heart attack or other signs requiring emergent cardiac intervention with the cardiologist. And then based on the neurologic status, the best next step is to determine whether the patient follows command. So getting a very good and thorough neurologic exam is imperative after achieving ROSC. If they are considered comatose and require targeted temperature management, a brain CT should be obtained as quickly as possible, as well as EEG monitoring to assess for any seizure-like or abnormal brainwave activity. And then further intensive care should be performed while in the ICU. If the patient is awake, they continue with standard critical care and keeping in line with all the things that we've previously discussed. And throughout the post-ROSC resuscitation management, maintaining ventilation, oxygenation, and hemodynamic stability are certainly the cornerstones of our treatment, and are using the appropriate medications and monitoring are necessary throughout this in order to improve their long-term neurologic recovery and long-term survival, hopefully out of the hospital.
So turning our attention to post-resuscitation care, particularly for patients who don't return to command following after achieving ROSC, there is a 2023 ACLS focused update, which goes into great detail about temperature management after cardiac arrest. So we moved away from the term targeted temperature management to temperature control. At the end of the day, all that we're doing here in terms of providing high quality CPR, ventricular fibrillation shocking, medication administration, and return of spontaneous circulation is so that the brain can continue to derive adequate blood flow and oxygen without incurring any additional neurological injury like what happened in Ms. Gupta. The history of temperature management is a very long one. It started way back in 2002 with the initial 2 trials that were published in the New England Journal of Medicine, looking at 33 degrees versus not providing targeted temperature management. And 33 degrees centigrade at that time seemed to be more effective than not providing any temperature management at all. In 2013, all of us jumped on the bandwagon at that time. And in 2013, the next set of study came out looking at 33 degrees versus 36 and found that both 33 centigrade and 36 centigrade are equivalent in terms of providing good neurological outcome. And 36 centigrade probably had less complications compared to 33. And then fast forward in 2021, we had a study looking at 32 to 33 centigrade versus keeping at 37. In other words, prevention or fever control. And that strategy also seemed to work. So this has really evolved over the last 10 to 15 years. And now we call it temperature control as opposed to targeted temperature management. But the bottom line is, any adult who does not follow commands after return of spontaneous circulation, regardless of whether they had an out-of-hospital arrest or they had an in-hospital arrest, there has to be a deliberate strategy for temperature control. Well, what kind of temperature do we recommend picking? The American Heart Association doesn't give us a particular temperature to pick, but does give us a range of temperatures in which we can pick. So anywhere between 32 to 37.5. And the key here is to prevent fever and to address fever and avoid our patients from becoming febrile. It is a class 1 recommendation to recommend, select, and maintain a constant temperature for at least 24 hours in patients who are comatose and who are not returned to following commands. We recommend hospitals develop protocols based on the location that you practice and the facilities that you have available for post-arrest temperature control. 60 to 80% of patients who survive their cardiac arrest, who eventually end up passing, is because of withdrawal of life support because of severe neurological injuries. And so temperature control is the cornerstone for preventing that. It is reasonable that whatever temperature we pick is maintained for at least 24 hours after achieving the target temperature. Now, are there certain subgroups of cardiac arrest patients? For example, somebody had a downtime for 5 minutes and others had a downtime of 30 minutes. Do we end up recommending different temperature goals for one subgroup versus the other subgroup? And we don't have enough guidance or evidence on that to suggest that maybe if you were down for 30 minutes, you would do better with 32 or 33, as opposed to if you were down for less time. We don't have that kind of granular data at this time. And you can also, very important, to prevent fever. In patients who are spontaneously hypothermic after they return to spontaneous circulation, we don't want to warm them any faster than 0.5 centigrade per hour. As far as pre-hospital is concerned, the benefit of strategies such as rapid infusion of cold intravenous fluids is not recommended. That is a level 3 recommendation, meaning it is no benefit and it actually can be harmful. We're recommending not to use the routine use of rapid infusion of cold IV fluids for pre-hospital cooling of patients after ROSC. So the bottom line of this very busy slide is, if your patient is not back to command following after return of spontaneous circulation, there has to be a temperature controlled strategy. Pick a temperature between these ranges, maintain it for 24 hours after achieving that temperature that you pick. So maybe you pick 36. So once they hit 36, maintain it for 24 hours. Don't rewarm any faster than 0.5 centigrade per hour. And there is no benefit to using cold intravenous fluids in the pre-hospital setting to get a kickstart on the temperature management.
excellent review. Thank you so much for that. Yeah, I always think about the takeaway as being just avoid fever if you can in these patients, definitely. Wonderful.
So next, in order to continually improve the performance and patient outcomes, it's important to leverage learning and improvement tools during and after resuscitation events. And so first, I think the most important thing during these is, and we've kind of alluded to this previously, is role clarity and closed loop communication. And so understanding who's doing what in the room and making sure that it's very clearly identified, especially in the beginning, so everybody is on the same page. And then maintaining closed loop communication of discussions, making sure that there's no extra chatter going on in the room and that everybody is focused on their role, while trying to make sure that the things that have been asked to get done are getting done and vice versa. And so that
Can I interrupt you? Sorry. I think when we say closed loop communication, I think this is a really important point of communication during a code blue type situation or ACLS. Can you give us an example of closed loop communication? And maybe you could pretend that you're the team lead and I'm one of your team, and maybe we could demonstrate what closed loop communication means.
Sure. So if I'm the team lead in the room and then Dr. Crawford is handling medications, I say, Dr. Crawford, can you please give 1 milligram of epinephrine? And then Dr. Crawford will respond.
I'm giving 1 milligram of epinephrine. It's in now.
Okay. And so then that is a way for us to communicate between the two of us, that I am clearly delineating this role to her, and then she is clearly telling me that she knows what needs to be done and saying that back to me and telling me that it has been completed so we can move forward with the next task. And this helps to kind of get rid of any confusion of whether or not a role has been completed or if a task has been completed. And I feel like in the long term, it helps further communication and improve patient outcomes. So if you have anything else to add.
Increases that chaos that can occur when there's multiple people in the room as well.
Yeah, totally. And so another thing that I find to be very useful is doing mock codes and then debriefs. And so mock codes are just a way for us to utilize these skills and continue doing them over and over and over again in order to make the cognitive load of remembering what the steps are less for each time, because in those situations, they become very stressful. And when you find yourself in a stressful situation, trying to decrease the cognitive load of what are the next things we need to do, less is very important. So understanding that epinephrine is given every 1, 3, 5 minutes and what shockable and non-shockable rhythms are, and understanding how the team dynamics work within that code is very important to move forward. So that way there's also, once again, less confusion and everybody continues to be on the same page. And then the debriefs I find very useful. This is for both mock codes and real codes in order for us to break down what happened, whether or not everybody felt like we were communicating adequately. Do we feel like we were all on the same page? Do we feel like we addressed the things that needed to be addressed with the reversible causes, as far as what medications were given, and just making sure that any grievances that may come about during the code situation, if we feel like there could have been something better or something that was done very well, that's acknowledged so it can be worked upon the next time or continued throughout codes going forward. And then lastly, I find that integrating ACLS checklists and cognitive aids are also very useful during actual events in order to help with the adherence to guidelines. It reduces the reliance on memory under stress because, as we've noted, having this stressful situation and trying to remember all the things can be quite nerve-wracking, and you may forget some key steps along the way. And then it also helps team remain focused on and organized throughout the entire event. So these tools work synergistically to build more confidence within the providers and competence, as well as hopefully a cohesive code team in order to improve overall patient outcomes, which is what we're all aiming for.
Okay. So we have to take in consideration that we can forget some recommendations, some strategies. We can be in the rush with the patients. We have been taking the checklist from the aviation but the pilots are sitting on the plane. It's really easy at the beginning of the plane, but we have our patient oldest. So the situation is completely different. So we can forget some treatments, as Dr. Kominsky says. So we really want that you can download this with this code and use the checklist and these cognitive aids, because they are going to help us, as in some scenarios like trauma or resuscitation settings where they have been validated. In cardiac arrest, the evidence is not too much, but definitely with these cognitive aids, we can try to stay in the same protocol and avoid some mistakes or forget some of the steps or repeat the dose of epinephrine 2 or 3 times. So definitely we need to try to maintain the adherence and trying to reduce the mistakes that we can have during the cardiac arrest. Also, you can get the Stanford Emergency Manual that is really usual, because at the OR, we can have many H or many T's difference than in emergency room. We have other causes that can be associated with the cardiac arrest. And finally, we can get one of these crises. You can see here some of the crises that can finish in the worst crisis, that is the cardiac arrest at the OR.
Yeah, thank you, Dr. Hans. I love this emergency manual for a few reasons. One, you can see that it has all of the ACLS algorithms at the beginning, but also if you're working in an operating theater or an ICU or even in the emergency department, many of these events can happen that are also considered emergencies. And even though I'm a very now old and experienced clinician, sometimes I don't remember all of the steps. So there's no expectation that we all remember everything. And so if we use these cognitive aids, it will help us not to forget any of the steps. I actually used the emergency manual just last week in the operating theater when we had a power outage, and unlike some operating theaters, there's no windows, so everything was completely black while I had a patient who was anesthetized. So we got the emergency manual out and worked together to make sure that the patient was safe and doing well. I'll also mention that if you use that QR code, you can download this manual. It comes in multiple languages. It comes in English, of course, but it comes in Mandarin and traditional Chinese, Dutch, French, German, Korean, Portuguese, Spanish, and Ukrainian. So lots of different languages for you and your colleagues if you want to download this manual.
So concerning debriefs, it's very important to always debrief after an ACLS administration of ACLS for a patient who had a cardiac arrest. So we'll answer this question: post-code debriefs in your hospital, are they always done, sometimes done, rarely done, or never done? You can see some are saying B, sometimes done. There's one who said never done. There's always done. Okay, rarely done. A good chunk between rarely done and sometimes done. It's important to do a debrief, and it's recommended that once we have an event, we should always debrief, because you want to see what did we do well, how effective was it, how effective was the system, how effective was the care that we gave, did we achieve our objectives in resuscitating the patient, and is it how did the healthcare professionals perform the resuscitation? Was their technique adequate? So once you now understand what went wrong, you can now be able to recommend and see maybe you need to have more simulations, maybe you need to have more scenarios in the hospital to at least improve the confidence levels and also improve the care that the patients will get during a cardiac arrest. I'll go to next. So this is showing a mock code simulation. So it's a simulation whereby it was something that was probably structured in the hospital or designed just to understand if everyone understands their role, or to just enforce that people understand their role and what is expected. Having these simulations are important so that at least it increases the confidence level of the providers. So what one change will you take back to your unit after today's session? Maybe you can write it down on the chat.
Yeah, I would like to give some time for our learners to really think about this. What change can you make? Can you help your teams organize? Can you improve role clarity? Can you improve communication? Can you talk to hospital leadership to ensure there's a code trolley in every clinical location? What are some things that you would like to change? Maybe Dr. Rachel, you can read some of the good ones out to the rest of the group.
So someone says establish clear roles, encourage on closed loop communication, ensure that the trolley is well equipped. Debriefing is also important. Role clarification. Someone else is also saying enhance simulation, mock simulations, teamwork, CMEs as well. Talk to hospital authorities to increase training of the teams. Encourage debriefing, improve role allocations. So majority, at least, there's something that we've learned, and there's something that probably we've had a refresher course to understand how important it is to have a seamless simulation, or not simulation, a seamless code blue response. So whereby we are able to understand and work as a team with defined roles, having equipment, having your trolleys ready, having people who know what they're supposed to do. So all these are things that we should all take home, all with the aim of improving the quality and care that we give our patients. Thank you.
Yeah, we have a few minutes left, so I think some of the questions may have been answered online, but we do have some questions in the Q&A, so maybe we can review those quickly. One is, suppose you don't have ECG to tell you if it's a shockable or non-shockable rhythm. When is it a shockable rhythm, and can compression only give ROSC? How would you answer that, panelists? You don't have an ECG. Yes, go ahead, Dr. Garcia.
Okay, I think that if you have the defibrillator, maybe you have the monitor with the defibrillator. So at least that is one of the best options that you have. The old defibrillators, I remember the monophasic is just the box, no monitor. That's going to be completely different. But usually defibrillators has the monitor. You need to know how to turn to paddles and monitor with the paddles, not with the cables for the other derivations. If you don't have how to monitor, it's impossible to make the difference if you have shockable or not shockable. It's just the monitor who can help us.
Yeah,
it's hard to decide.
Very difficult question. I would say too, if you don't have any monitor at all, and you don't have a pulse, that the most important thing would be Dr. Lawrence's high quality CPR. But also at that point, if you do have access to adrenaline or epinephrine, you could try to give that adrenaline or epinephrine and then continue your quality CPR and see if that would increase your chances of return of spontaneous circulation. What do you think, Dr. Lawrence?
Yes, I totally agree with you when it comes to that. I have worked in centers where you don't even have a monitor, nothing available. So in that situation, you are compelled to do something, which is not the standard. But if you don't have monitor to even decide whether it's a shockable or non-shockable reading, you can assume a non-shockable reading and go by the non-shockable reading. But you can't assume a shockable reading. Because if it is a non-shockable and you are shocking, so you may assume a non-shockable reading and go by that. But it is not That is not it. It is not the right thing to do. Get a monitor. And that is the reason why we are having these trainings and webinars, so that as policymakers, as doctors in the hospitals, we can start preparing towards that. So if you are involved in hospital procurement, hospital policy making, you can start preparing that before the patient even comes. So preparation is very, 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 very,
Yeah.
and it's something that we have to work on. So anytime I'm doing the training, I have had to train in places in Cameroon, in Nigeria, in Sierra Leone. So it was one of the questions that I tell them, you are the people listening this webinar, can go and make the change. Start by preparing before the patient even gets the cardiac arrest in it. Thank you.
Excellent. Thank you, Dr. Lawrence. Yeah, I think the last question we asked is what change will you make in your institution? And if you don't have a monitor, that would be the top of my list, is to make that change. We do have one more question that I'd like to ask the panelists, and that is, when do we stop doing CPR? When do we stop? When do we say enough is enough? One person answered when the pulse returns. So obviously, if you have the return of spontaneous circulation, that means that you have successfully resuscitated the patient, and you would stop CPR at that point. But what if you don't have a pulse, and what if you don't get return of spontaneous circulation? Can we hear from our panelists? What are some of the things that you consider when stopping CPR? Dr. Andrea or Dr. Rachel, Dr. Chitra, Hans?
Okay, now Dr. Chitra, please.
I was going to say, I can speak from the neurological point of view. We used to think that, with 20 minutes, 25 minutes, 30 minutes, these patients are never going to do well. But that is not true. It is true that the likelihood does decrease, but we can never say it's an absolute. So at least from the neurological point of view, I would say, don't use that as an arbitrary time limit cutoff in the thought that, this patient is going to be severely and permanently brain injured from which they're not going to recover. So I would say don't use an arbitrary sort of like time limit cutoff, but I let the other panelists answer it from their experience.
Yes, usually 20 minutes is the cutoff for stopping the CPR in the majority of the cases. The problem is when we don't know when the patient get the cardiac arrest. Usually that is a difficult point to know when the nurse or the physician enter into the room, the patient is unconscious. How many times has happened between the cardiac arrest and when we make the diagnosis? So it's going to be complicated. Different if we have the patient monitoring at the OR, the ICU, the emergency room, and it's completely different. And maybe we can prolong the CPR in some cases when the patient fall down in a cold lake, when they are really with hypothermia. There are some cases that the brain could be safe because of the temperature. So maybe there are some cases that we can consider prolong the CPR, but usually 20 minutes is going to be enough.
Yeah.
Okay.
Go ahead.
Can I add something? Yes. So just to add to what the other panelists said, it's also case by case scenario. So it's case by case scenario. So let's say you have a case, in addition to what they said, you have a case that the outcome of the condition is not compatible with life. You may decide to stop the CPR. So if you have something that the outcome of the condition of the patient is not compatible with life, it's something that you will not want to continue it. And then also looking at if usually when we are doing the training, we emphasize that we have the reversible causes of the cardiac arrest. So as much as possible, try and make sure that you identify the reversible causes and treat them before you can call off the code. So before you can say, I'm stopping a CPR or I'm stopping a code, try to get the reversible causes and correct them before you can say that, oh, So in addition to all that, thank you.
Excellent. Thank you all so much. I really want to give a big shout out for our panelists. I think this discussion was excellent. I do want to acknowledge that this is not an ACLS certification course. This is merely a discussion of how ACLS can be successful, or some of the things that will limit the success of ACLS within the hospital. So we're not discussing out-of-hospital cardiac arrest. I also recognize that we did not discuss pediatric patients or obstetric patients. The recording, the slides, everything will be posted to the Learning Resource Center. That link was placed in the chat at the very beginning of this webinar. You can also scan the QR code on the slide that you see there. I also want to encourage all of you to claim your CME. If you registered for this session, you will automatically receive a certificate of attendance, but you will also receive an email notification from Stanford's CME. This will occur within 5 business days. It doesn't happen immediately, so be patient. Within that email, you will have instructions on how to claim your CME. Please follow those instructions in that email. Additionally, I do want to acknowledge some of the challenges that we have recently faced. Some of our colleagues across the globe have been unable to access our webinars due to US sanctions, which makes us very frustrated and also very sad that some of our colleagues do not have access to these great discussions through the live webinars. So I do want to encourage all of you to share with your colleagues that these webinars will be live streamed on our YouTube channel. And additionally, these recordings will be posted to the Learning Resource Center. So if someone misses this webinar, please encourage them to follow the discussion either on the YouTube channel and or on the Learning Resource Center. Again, I want to thank our panelists, but also really want to thank all of you, our learners. We're so inspired by you working every day to take better care of your critically ill patients. It's very admirable, the work that you do, and we're so grateful that we're working alongside each other. So thank you so much to everyone, especially our wonderful panelists of today.
Thank you, everybody.
Thank you.
Okay, thank you. Thank you very much. Bye.
Thank you.
Thank you. Bye.
Thank you. Thank you.
Thanks. Many
Thank you
thanks.
very
Bye-bye.
much.
Thank you.
Thank you.
Thank you.
See you next
Thank you.
Thank you.
Bye.
Bye.
Thank you. Bye. Bye.
Thank you. Bye-bye.
Bye, Joe. Bye, Dr. Maria. Bye,
Thank
Dr.
you.
Maria.
All right.
Thank
Thank
you
you.
so much.
You enjoy.
Bye. Thanks a
Thank
lot. Bye.
you. Thank you very much. Dr. Maria. Bye.